Everybody, and good evening. Welcome back to our returning participants and to anyone who's joining us for the first time. I appreciate you joining us tonight. Before I introduce myself, I would like to turn your attention to the first of 3 polls that we have for you tonight. You should see the poll right in front of you, so just please answer at your leisure. So just to give you some background on the virtual grand rounds, the AADMD virtual grand round sessions, they seek to create a space for mentorship and exchange of knowledge and experience between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of the grand round session is to expand and strengthen the IDD healthcare workforce across the spectrum of experience levels. So I'm going to close this poll and I will share the results with you. So you can see the question was, which profession or role do you represent? And so our results are 21% of our participants are administration, 14% are students, 0% is medicine, which is new for us, 29% are coming from dentistry, and 36% represent the other category. So I'm just going to hide this and pull up the next poll. So once again, feel free to answer at your leisure. So at the end of the session, I will send you a link to a quick survey we've made. It shouldn't take more than 5 minutes, but it's very important for us that you do fill it out. The feedback we receive from this survey allows us to improve the virtual Grand Rounds experience, and we also like to hear what future presentations you'd like to have us organize. So with that, I'm going to publish the results from our second poll. So the second poll question asks, in what stage of your career are you? So we have 13% of our participants joining us from pre-health professional training, 27% joining us from health professional training, 0% joining us from residency, 60% are currently practicing, and 0% are retired from practice. So I'm going to just pull up the last of the polling questions. So tonight, we have a special virtual grand rounds. It's at a different time on a different night because we organized 3 different presenters from different fields, different backgrounds to present on a case. So our first presenter will be Dr. Seth Keller. He's a board-certified neurologist in private practice with Advocare Neurology of South Jersey. He specializes in the evaluation and care of adults with intellectual and developmental disabilities with neurological complications. He's also a previous president of the American Academy of Developmental Medicine and Dentistry. We also have joining us Dr. Evan Spivack. He's currently a professor and director of the Special Care Treatment Centers at Rutgers School of Dental Medicine. He has devoted his career to both direct patient care and to the education of future dentists in the provision of dental care to persons with special needs. And our last presenter is Dr. Lucy Esralew, and she specializes in brain behavior clinical work with individuals with developmental disabilities within the geriatric population. And she is a certified clinician through the National Association for Dual Diagnosis and a certified dementia practitioner and trainer through the National Council of Certified Dementia Practitioners. So with that, I'm going to close the last poll and review the results. So the poll asks, what do you hope to gain from this webinar? And we have 24% said they would like to learn foundational healthcare concepts for individuals with intellectual and developmental disabilities. 0% said networking. 53% said gain interprofessional perspectives on healthcare for I/IDD. 18% said gain pearls from complex and challenging clinical cases. And 6% said to gain CE credits. All right, so I'm going to hide that. And with that, I will hand the floor over to Dr. Keller.
Thank you very much, Michael. Hi, this is Dr. Seth Keller. I was very interested in the fact that in the poll, no medical people, very interesting, and just the last poll, gain interpersonal perspective, which is really great because, folks, that's kind of really what a lot of that we want to do this evening is talk a lot about not just the case, a challenging case that you're going to hear about, but listen carefully on how we propose and how we as colleagues and professionals work together, and so there's going to be an underpinning in a lot of what we really do want to review in that regard. So with that in mind, just to kind of some basis on where the big picture is for tonight. First of all, the issue about working with a case or with an individual is certainly might be quite obvious to everyone probably listening, is who is the individual, who's the patient, who's the person, what's the background of the family, their support network, and why do they have a developmental disability or intellectual developmental disability. So as we go through this, the importance of each of these, hopefully as we describe it, will become self-evident. We're going to certainly review a non-pharmacologic perspective on this particular case, as you're going to hear Dr. Esralew focusing a lot on. And Dr. Spivack will be speaking in great regard in terms of the issues regarding this individual's situation with oral triggers for their challenges, as you'll hear. And I'll be speaking in some respect about underlying medical difficulties for this person. And then finally, as we come to the crescendo, as they say, we'll be talking about the big issues and the contributing factors, but also in relationship at the final part of our conversation, that's going to talk a lot more about the issues of multidisciplinary approach, how you do it, why you do it, and give folks some perspective. And then we're going to have time, hopefully, with a question and answers, and we'll do our best. So just to kind of get through this and make sure I have time for be able to get through this and get everyone to bed tonight, our case is an amalgam. And what I mean by amalgam is that we really were thinking of an individual or case where we would really try to hit the points that would highlight oral health issues with underlying medical issues and psychological issues. And so what we're going to be pulling tonight is true case examples pulled from various aspects of each of our backgrounds, who we know. So a lot of it is really truly based on a real case, but we made it nuanced that would fit and teach and show different issues. So we're going to be talking about Debra. And Debra is a 35-year-old woman who lives with her mom. And we'll get into the issues with mom and maybe what that's about later. And Debra, she has a neurodevelopmental disability, and I'll mention what that is with Dravet Syndrome a little bit later. She's really not the greatest compliant with her medications. She comes to the office setting with her mother, who's her main care support, and really the main issue that the mother is concerned about is Debra's lip. She just keeps biting her lip, and that seems to create more and more problems. Her underlying history is she was born with intellectual developmental disabilities, and she's had spastic quadriplegia her life. She has a seizure disorder, which has been thought as being Lennox Gastaut, and I'm going to have a slide or two talking about Lennox Gastaut, and ultimately she was diagnosed as having Dravet Syndrome. So that's a very basic background as to Debra in some capacity of her life. Whoops. Well, the issue started when she actually had a seizure, a type of a seizure called a drop attack, and that's basically when someone loses body tone. And with that event, she fell and she bit her lip. And you're going to hear more when Dr. Spivack talks about it, how it really becomes more, this is more than just a bit lip. She's been continuing to bite the lip continually, causing more and more difficulties for the last 2 weeks and so. And the backstory, which I kind of added and want to make sure that this is not the first time this has happened to Debra, because she has a seizure disorder, she's got gait dysfunction, she also has fallen and has had previous mouth and facial injuries before. Just as a background on her size, she's 63 inches, 42 kilograms. Her verbal skills are very limited, and that will become some importance as we talk about in terms of how it is with the particular case. Her comprehension level is fair. She can follow simple commands and instructions, but it's really not superlative. Her gait dysfunction, she has spasticity. She can walk unassisted. She does not use she is not currently in a wheelchair. And there is a long history of spasticity previously in treatment as a young child. Now she's in her 30s. And just the underlying diagnosis, just again, she has been diagnosed as cerebral palsy at birth or within the first year or so. Spastic quadriplegia is part of her cerebral palsy, and her intellectual disability was most notable when she was born. She began having seizure and seizure types when she was an infant. And I'm going to talk about that in more respect. She's had bronchial disease, bronchitis a number of times. She also has had type 2 diabetes, thyroid dysfunction, and of note, challenging behaviors. Because of swallowing dysfunction, she's had been fed via a PEG, but there is times at which Debra is able to take certain meals by mouth, but mostly she gets a lot of her nutrients and even some of her medication via PEG. And here's a list of Debra's current medications. And as of note, she's on a Depakote for her seizure disorder at 2,000 milligrams, Onfi for her seizures at 20 milligrams twice a day, and the other medications, as you can see on the slides, just to round it out, Seroquel, Ativan for behavior. She's on Baclofen, 10 milligrams rather, 3 times a day for her spasticity, and then generally she's on medication for her breathing, thyroid, and vitamin D deficiency from loss of that and bowels. So that's generally her list of current medications. And these are just some updated labs just to kind of round out information of where her blood levels are. Her valproate VPA is 72, which is therapeutic. And down the list, other labs are within normal limits for white blood cell count, blood count, H&H, sodium, potassium, liver, AST, ALT, liver, and I added ammonia level, which is NH3, just to give some perspective of whether or not the Debra has been toxic or encephalopathic at times, causing a confusional state, which will be thrown in the mix of this story, maybe. And I think really what's important to appreciate as we get into the case presenting to the practitioners is her underlying neurodevelopmental diagnosis, Dravet Syndrome. And Dravet Syndrome is known as a severe myoclonic epilepsy of infancy, even though she's certainly now 35. It's a syndrome that's associated with intractable epilepsy in those that do have associated cognitive, motor, and behavioral difficulties. And genetically, it's been found in 80% of cases. There's a mutation which is affecting the sodium channel. And this is something specifically that could be found on genetic analysis. And as an aside, she was not really diagnosed with Dravet syndrome until about 5 years ago because of the fact that many years ago the ability to do genetic testing was not even known about. She's had the difficulties in typical case of DS or Dravet syndrome is typical seizure onset is like an infant, less than 12, and usually it's really unremarkable usually in people with Dravet's where they might have a normal development, normal brain imaging, but the seizures themselves and pleomorphic means that it's basically very different types, generalized tonic-clonic, jerking or myoclonic, atypical absence, and what she has also as part of her seizure syndrome is she does have drop attacks, which is really on the next slide as I talk about it, talks about the question that she actually carried with her as even Lennox Gastaut. Her milestones really she was normal early on, but her progression actually happened quite early as just a few years old. She slowed her skills, plateaued, but what happened as she became in her 30s or even late 20s, she regressed even further. She actually became more and more ataxic and lost more skills. And that actually does happen in Dravet syndrome where they become more spastic and have more and more progressive disease as they become adults. So there's a whole adult component of it. It's not a common syndrome. Dravet syndrome was named after a French epileptologist a number of decades ago, named after her, Dravet, and it's estimated, as you can see, the incidence is quite rare, 1 in 16,000 or so. They have common sleeping difficulties, infections, sensory integration or processing disorders, which Dr. Esralew will take upon, disruption of autonomic dysfunction, body temperature and sweating, and unfortunately, because the seizure difficulties, a high incidence of sudden unexplained death in epilepsy, which is what SUDEP is. is. So the concern about early death is really concerning because of a SUDEP as well as swallowing dysfunction, falls, and other complications that happen in this. They're usually medically refractory, meaning that medications don't work. And as she is on Debra, she's on valproic acid and clobazam, which is Onfi. And these have been found to be the top drugs that seem to be working. Other drugs, AEDs, anti-epileptic drugs, Topamax, levetiracetam, which is Keppra, and others have been notable for this helpful, but interestingly enough, lamotrigine or Lamictal or carbamazepine or tegretol seem to kind of make them worse. Other options for seizure control that I've worked with in Dravet and others, vagus nerve stimulator, ketogenic diet, and even medicinal marijuana. So if we have time, we might talk about that. And there's a high rate of, unfortunately, a death because of the complications. So it's a very challenging difficulty. But literally, what she had been diagnosed as throughout most of her life, even in pediatrics, is Lennox Gastaut. And you might think of this as very similar to what you might think about Lennox Gastaut, however, is really more of a generalized form of a syndrome, and it's actually caused by many underlying neurologic or primary neurodevelopmental dysfunctions. It's also multiple seizure types, including atonic, which are drop attacks, tonic, which are stiffening, and they have a specific EEG or brainwave pattern. And intellectual developmental disabilities is very, very common, and its prevalence is about 1 to 10% of all childhood epilepsies, and also incidence rate for Lennox Gastaut is around 0.6 for just all general onset of epilepsies. And it starts around age 3 to 5, males and females in terms of the differences, as you can see. Not much, but there are some differences. And the estimates of 10 to 40% in children also have early onset as other seizure types called infantile spasms. The diagnosis and treatment are difficult, and it's a really challenge as they expand into the adult world carrying these diagnoses and challenging seizure types. The difficulties that are often challenging that have happened with her are really related to challenges and concern for even her oral health that might lead to difficulties to challenges that Debra might have. Things that might also be challenging are reflux or irritation. Dizziness might also cause falls. Headaches might also cause difficulties as in her medical problems. Neuralgia or facial pain, and cervical radiculopathy or other triggers that might manifest as some of the things that she presented to like the medical doctor's office of having a facial pain or the injury that did happen to her. The main difficulties that we're going to be talking about are really the main treatments that Dr. Spivack is going to talk about. So I'm going to hand this right over to Dr. Spivack, and Evan, I'm going to hold on to it. So if you want to, go on, and I'll just move the slide for you.
Sure, by all means. Good evening, everybody. I'm Evan Spivack, and I want to thank you all for coming to this evening's virtual Grand Rounds. I'm particularly happy to really see so many, at least such a percentage of our audience be coming from the dental world. Dentistry very often it considers itself, and traditionally has been, very much of a cottage industry. It's been very much a profession of working in our own individual silos, and the importance of this presentation in particular is really to highlight the importance of reaching out to our colleagues in all aspects of the medical world to really reach an ability to treat and to care for a very, very complex patient. And certainly Debra is one. And as soon as she presented to our care, it was very, very obvious that this was not something that was the standard type of patient that we might see in terms of some types of self-injurious behaviors. Debra comes in to our office with her mom, and mom is distraught. Her daughter has been biting her lip constantly ever since her fall. She initially suffered the fall and injured her lip at that point in time. Ever since that point in time, she's been biting her lip. We can kind of think about that from the perspective of the patient who is not otherwise intellectually disabled, who, you bite your lip, perhaps you have a cold sore or something along those lines, and you tend to bite your lip, and you'll play with it for a while until all of a sudden you realize, hey, I've got to stop playing with it. I've got to allow the lip to heal up, or it's just going to continue to get worse. With Debra, that's not happening. The more that she bites, the more injury that we see to the lip and to the surrounding tissues, the worse things seem to get. And Mom is really at the point right now where she really needs help. She says this is getting really bad. And as you can see from this picture right here, this is the initial presentation that Debra had to us, and it was a very, very bad and obviously painful situation. In terms of trying to talk to Debra to ask her about it, we're struck by the fact that her limited ability to communicate with us is going to present a lot of challenges. It's going to present challenges in terms of our ability to get information from her about what's going on, about what's triggering the cause of lip biting, and also we can recognize that this is going to create some issues in terms of our ability to get information to her as well, to make sure that she's able to understand what we're trying to do, how we're trying to do it, what the goals are that we're trying to achieve. So the communication back and forth is going to be very critical. The point was made that Debra's fed via PEG for the most part, and that's really critical. In some cases where you have a patient who's fed via PEG entirely, we might have a few more options in terms of saying, well, let's take out these teeth, and perhaps that might be more readily acceptable as an alternative. In this case here, Debra's being fed orally, and she's receiving a good amount of her feeding orally, so we really want to try to avoid the extraction of any teeth if we at all can. Obviously, as any of my dental colleagues would say, there are several reasons to avoid trying to take out these teeth. But in a case where someone is dealing with these teeth and using these teeth for feeding, clearly that becomes something that we need to think about as well. One issue which is not necessarily evident just from looking at this picture, but which is going to become important as well, is that the oral hygiene that Debra presents with is not great. There's a significant amount of plaque on the teeth. There is food debris that Mom points to in discussion. We talk about how the oral hygiene is beyond this point in time. When we're at this stage of the game where the mouth is really just so beaten up, with lips being bitten, where there's so much trauma, obviously getting in there and trying to brush the teeth is going to be difficult. Trying to maintain any sort of home oral hygiene is going to be difficult because it creates even more pain. And so Mom's been trying to avoid that. Next slide, please. So our goal within the dental aspect of this case was to say, what can we do to get Debra out of pain? What can we do to allow the lip to heal up as best as it can? And at the initial presentation, we don't know how well that lip is going to heal up. We go ahead and we're able to make impressions of Debra's mouth, not without a great degree of difficulty. Debra is very clearly able to express that she's uncomfortable and she's not enjoying the process of making those impressions. It's really uncomfortable getting impression trays past that lip. And as a matter of fact, the picture that you see on the lower left side of your screen, that's the picture that was taken before we made the impressions. Debra became very agitated after we took those impressions as a result of the pain, as a result of her inability to really communicate, and that frustration took itself out on her actually biting her lip even more. So this first picture that you see, is actually the pretty picture before things got really bad. But we were able to go ahead and get an impression, and from that impression we made a mouth guard. And this mouth guard we were able to secure with clasps so that it would be removable, but it would be able to be stable enough in her mouth. And we fabricated it with a lip bumper. The lip bumper is basically an extension of the mouth guard further forward to basically push the lower lip out of the way so that when Debra was biting down, she wouldn't be able to engage the lip. As long as she wasn't able to engage the lip, then she'd be able to allow that lip to heal up. And we didn't know how much healing we'd get, but within a couple of weeks we saw very, very significant healing. The picture on the lower right shows the lower lip healing extremely well after only about 2 to 3 weeks. So we had very, very good success with this. The issue of maintaining the guard in place was actually an extraordinarily difficult one. Debra responded very well to music therapy in terms of this. That was able to distract her from kicking the guard out. It seemed to calm her down significantly, and it played a major role in allowing the healing to occur in this early stage. Next slide, please. Next slide. Great. So everything went fine. Debra was a patient that we followed on a regular recall basis. essentially every 6 months. She was doing extremely well. The lip had healed up beyond that point that we saw before to essentially a normal lip. She was doing well. She was happy. Mom reported no problems at recurring recall visits, so everything was working very well, at least for the first couple of years. 5 years later, all of a sudden, Mom comes back, and again, she is just besides herself. Debra had started biting her lip yet again. This time, however, there was no specific precipitating event. There was no fall that caused her to all of a sudden bite the lip that started this whole thing off. She just had started biting her lip for no real apparent reason. There was no change in her medications. There was no specific medical change that we had noted. We went into a very thorough review of all the medical factors that there were. We couldn't really find anything. There were no significant social changes. Everything was the same at home. Everything was the same in her school. There was no significant change in terms of the people that were interacting in her life. There were no changes in her diet. By a neurologist, an MRI was performed, and there were no novel findings of that MRI as well. So basically, we were looking at something, wondering why is it that she's going ahead and biting at this point in time. You can see that the biting really was causing a significant amount of trouble. The lip is really pretty beaten up at this point in time, that lower lip, and even the upper lip to a certain extent is starting to get some injury to it. So things were getting pretty bad. What you can't actually see is that even the insides of the mouth, the insides of the cheeks were getting bitten as well. So Debra was extremely unhappy. It was very, very clear that she was feeling the pain significantly, and but even despite all that, she couldn't stop. We tried fabricating a mouthguard for her, actually similar to the one that she had had years before. We fabricated the mouthguard for her. We gave it to her. We actually included some more clasps in it so it would be even a bit more stable. But at this point in time, despite the use of any types of therapy, Debra was not tolerating the guard. She would kick it out entirely. She would express more agitation when she was wearing the guard in place. So the decision was made to try to figure out what can we possibly do to make things a bit better. Before we get to that, I think we need to look at the question of what was actually causing this biting in the first place. So next slide, please. There are a number of possible dental etiologies of oral self-injurious behaviors and the cause of pain. The real question is, what is causing her the pain that's causing her to bite down? Because she clearly was in pain. When we would ask if she was in pain, if things were hurting, we got her nodding, and it was very clear that she understood that we were asking her about her pain. There are several different areas that can certainly cause that type of pain. These are 5 different areas: bruxism, TMJ-related pain, dental caries, periodontal disease, and erupting and unerupted teeth. And let's go through these just a little bit. Next slide, please. So if we take a look at bruxism, if we take a look at the grinding of the teeth, certainly grinding the teeth can cause a tremendous amount of tooth damage. If you take a look at the picture towards the lower right, you can see the teeth ground down. You can see the amount of tooth structure loss, and that has a significant number of problems that's going to cause for the mouth overall. One of the real issues that it will cause, however, is demonstrated in the diagram that you can see on this slide as well. The tooth is held in the bone by a number of fibers, and the fibers that hold the tooth in the bone in some cases are pain fibers, which are meant to stop a person from biting down too hard when they get into a situation where the bite may be injurious to the teeth. When a person bruxes, when a person grinds their teeth this hard, when they're clenching this hard, those fibers are stressed, those fibers are torn, and that can cause significant pain, and that pain can be generalized throughout the mouth. So bruxism certainly is one of the concerns that we have. For many of our patients with developmental disabilities, bruxism is a significant part of what we're seeing within the overall picture of our patients, and certainly that was the case with Debra. We were seeing examples of bruxism looking at the biting surfaces of the teeth, on the occlusal surfaces of the teeth. So bruxism was one issue. Whether that was the entire cause or not, however, was yet to be determined. Next slide, please. TMJ-related pains are another very significant cause of pain within the entire face, and again, this comes in many cases as a result of clenching. It comes as a result of a poor occlusion, of a poor bite, of a poor jaw relationship, and TMJ-related pains can express themselves in many different ways. The pain is not localized to one specific area, but instead the pain travels the entire the entire aspect of the face up towards the head. Very often patients with TMJ disorders or bruxism-related TMJ disorders will complain of headaches. They'll complain of pain in the jaws, especially in the posterior part of the face, in the angle of the jaw. They'll complain of pain in the ears, sometimes a pain that very much is undistinguishable from an earache type of pain. So TMJ-related pains are very significant, and they are tied into bruxism as well. So let's see the next slide. The third possible cause of pain is dental caries. And when we're talking about a patient who has poor oral hygiene, where it's difficult to get in the mouth and brush, where our patients are peg tube fed, and therefore while they're getting some food by mouth, that food is going to be a pureed type of consistency for the most part. That's the worst type of diet that a patient can have from a dental perspective. It leads to food being pouched. It leads to an inability to self-cleanse the mouth. And so dental caries become more of a consideration in our patient population. When we're seeing these caries, obviously, the dental decay is going to be something that as it gets deeper, it's going to cause sensitivity to hot, to cold. It's going to cause pain as these areas of decay increase. Even on the uppermost picture towards the upper right side, you can see that even with the presence of some fillings, there will sometimes be decay around those fillings as well. So dental caries certainly is another consideration that we have to think of in terms of our possible etiology of the pain of what's going on with Debra. Next slide, please. Another problem is periodontal disease. Periodontal disease, again, damage to the gums, destruction of the underlying bone that's supporting the teeth, again, depending on how severe the periodontal disease is. Periodontal disease is a rampant, significant problem with our patient population in general, with patients with disabilities who are not able to brush their own teeth either because of physical concerns or because of cognitive concerns. This is a tremendous problem. Again, dealing with a pureed diet, dealing with a partial oral diet, we're going to see more concerns like this. What you were able to note from the picture of Debra early on was that Debra's mouth has an open posture, and this leads to an open-mouthed breathing posture, which dries out the gingival tissues, which again leads to an even worse situation with periodontal disease. Given the fact there was a significant amount of plaque, and given the fact that mom, even under the best of circumstances, had limited ability to clean her mouth, periodontal disease was another factor that we had to take into account for her. Next slide, please. And the last consideration that we have to think about when we're talking about the possibilities for pain in many of our dental patients, or at least one of the major ones, is the possibility of teeth that are erupting or teeth that are as yet unerupted. The picture that you see towards the middle of the screen shows a tooth, a third molar tooth, the wisdom tooth, that's starting to erupt. The gums around it, as you can see, are starting to split. They're somewhat irritated by the bite from the teeth up above. That causes a significant amount of pain. In some cases, it can become infected and require the use of antibiotics and analgesics as well. If we take a look at the X-ray next to it, what you can see is you can see a tooth that's not in the process of having erupted yet. That tooth, the way it's angled, is essentially hitting into the second molar tooth that's upright in front of it, and that can cause significant dental decay, and that can cause significant pain as well. So we see are lots of situations where we certainly have to figure out, is there a dental component to the pain that our patient is expressing? That can make it very, very difficult to actually diagnose the cause. If our patient has limited verbal ability, we can't really ask a lot of the questions that are a part of our normal dental workup. It's very, very easy for us in general to ask the majority of our patients, where does it hurt, when does it hurt, does it hurt when you're eating something hot, something cold? We use those verbal clues as hints to help determine a diagnosis. With Debra, we really didn't have a lot of that, and it made our ability to diagnose what was going on with her fairly difficult. With this, I'd like to turn it over to Dr. Esralew to discuss the behavioral considerations that were to be considered.
Yeah, thank you. And good evening. I want to thank my colleagues, Drs. Keller and Spivack, for preceding me. I'm going to bring in another perspective for the multidisciplinary team, and that is the behavioral perspective. That this is non-medical, and understanding lip biting as a severe injurious behavior, one in which, of course, she can sustain significant tissue damage. So the question is, how do we begin to characterize this behavior? And the person who's a behaviorist, whether that is a psychologist or another behavioral interventionist, does that through collecting data. The primary way we collect data is by observing Debra and trying to establish the frequency, intensity, and duration of her lip-biting behavior. We might involve her mom, and if she has any staff, in ABC charting, looking at antecedents and consequent conditions that surround the behavior of lip biting. And we also want to understand the function. In behaviorism or behavioral approach, we're thinking that behavior has some function, and we're looking to see what function it may fulfill, and a motivational assessment scale, which can be completed by the mother and staff at the guidance of a behaviorist, can be quite helpful. So we did identify some triggers for Debra. We found that among the things that were associated with her initiating lip-biting behavior were ambient noise level and her entire level of stress or arousal. Additionally, episodes were more likely to occur if her mother or staff were in another room or within the same room as Debra but attending to someone or something else other than Debra. Episodes were less likely to occur if Debra received social attention or engaged in a preferred activity such as listening to music, as was mentioned before. So when we're looking at behavioral patterns, which is what we're doing at functional behavior assessment, we want to know the conditions in which the behavior occurs, but we also want to know the conditions under which the behavior does not occur. And this gives us some clues in terms of shaping that behavior. Next slide, please. So there are a number of contributions to Debra's behavioral problems. Now, she does have a significant and complex seizure and neurodevelopmental disorder, as was described by Dr. Keller, and that's going to be with disruptions in brain activity. There is some likelihood that there's going to be some disruptions in behavior. We're possibly going to see heightened impulsivity and hyperactivity, which has been associated with Dravet Syndrome. She's going to have sensory integration problems, meaning hypo or hypersensitivity to certain senses and sensory stimuli. She has, as was already described, limited language skills, so that means that she's not going to be able to express her needs, preferences, and interests at the degree to which she might need to. It could lead to frustration. She has some difficulty relating to others because of her limited communication skills, and she has a limited coping skills repertoire in which to deal with emotional stress or excitement. So based upon our observations of Debra and the data collection, we had already identified the triggers, and we identified the functions of her lip-biting behavior to include sensory stimulation and attention. And just to dwell on this for a moment, we know for individuals who may be lower functioning and may be challenged in terms of their skill set, that self-injurious behavior can serve to actually help calm them down. There's a lot in the literature about how individuals release kind of a natural kind of anesthetic, or not anesthetic, but sedative quality in terms of neurochemicals through their self-injury. And then we identified also, the previous slide, that social attention seems to be an important function of her behavior. Additional triggers seem to include that she can be easily stressed, and that she does, of course, have limited coping skills in which to deal with that stress. Next slide, please. We want to pay attention not only to Debra, but to her mother. Because she is her primary caregiver and advocate in terms of health care. Very important to focus upon the family or professional caregiver in a situation in which we're hoping to shape or influence behavior. In the case for Debra, there are a lot of demands upon her mother to provide constant attention and supervision for this lip-biting behavior, because Debra really needs to be within line of sight supervision, particularly as we think about shaping that behavior. We really are going to be working with the mom on providing a rich or enriched environment in which Debra has opportunities to be distracted and engaged, and we want to provide opportunities for social attention. So what does mom possibly need? Well, mom, with all the demands upon her for caregiving of somebody with a significant maladaptive behavior, probably needs opportunities for respite, and we need to identify ways to support mom, including but identifying other sources of help with household chores and providing the mom with specific training in caregiving strategies. We want to help her establish a positive routine for Debra, and we have identified that Debra enjoys music. She also enjoys water play, and we want to give Debra access to these preferred activities which have a calming function for her. And we want to help the mom establish, and if Debra has any staff also, provide positive attention on a scheduled basis, but we have to come up with a schedule that's going to be easy to deliver by the mom. Next slide, please. So another way of looking at lip-biting behavior is looking at it within a class of behaviors that have been called body-focused repetitive behaviors, BFRBs. And in that same category would be trichotillomania, hair pulling, and skin picking. And there seems to be what the literature suggests is that it falls within a category of pathological grooming behaviors, and it's linked to anxiety. So individuals engage in behavior such as this because they have an impulsive urge, and they respond to that impulsive urge via compulsive acts, and those compulsive acts are self-injurious behaviors. So if we consider the possibility that Debra may be anxious, and this may be driving or continuing to maintain lip-biting behavior, we could utilize methods to decrease Debra's anxiety and overall stress level. Again, such possibilities as music, water play, and control of ambient noise level all can help Debra relax. And we want to develop a menu of reinforcers for Debra and give her praise and those tangible reinforcers when Debra is not engaging in lip-biting behavior and when she is engaging in positive routine as an alternative to lip-biting. Next, please. We know that individuals with Dravet syndrome have sensory integration problems, and that could include sensitivity to changes in ambient or body heat, and photosensitivity, including sensitivity to flashing lights and visual patterns. There's also reported sensitivity to loud volume. So there are a number of ways in which individuals who are working to help those with sensory integration problems. There's some resources. One is people sometimes use cooling vests to help with body temperature, the access to snoozolin or other multisensory environments, music and water play, fiber optic strands, which those of you who might be familiar with snoozolin products and multisensory environments very often are made available as resources within that kind of situation. Next slide, please. So we also identified that social attention issues or the need for social attention are among the factors that maintain lip-biting behavior when we did an assessment of Debra's function or what purpose her lip-biting served. So we want to provide opportunities for short bursts of positive attention. Individuals with Dravet syndrome may demonstrate autistic-like traits, and we do know that Debra has limited language skills and she does have limited social skills. She does not have age-appropriate ways in which to engage others. So we want to structure those opportunities for Debra because we know those are reinforcing. And if that is a function of her behavior, we want to make social attention, quote-unquote, legal and give her opportunities to get it. So Debra or staff could spend time looking at magazine pictures together, engage in water play or another preferred activity. Her mother and staff can engage Debra in brief conversations about her day. And praise should be given non-contingently. In other words, as many opportunities to lavish praise on Debra without her needing to do anything in particular to earn that praise will be helpful for her. Next slide, please. One of the big challenges for Debra is that she does not have extensive communication ability. She has a limited ability to express her wants, her preferences, and her needs. In fact, her resorting to lip biting may be a way of communicating unmet needs. Some of the ways in which people, or one of the ways in which people have addressed this limited communication repertoire is to develop a picture exchange communication system, PECS, in which you offer pictures as a way of symbolizing various things that people prefer, such as snacks, can indicate an icon for a need for a break and train her on the use of this when she wants someone to give her a hug or verbal praise, or there's another tangible item that she wants or something that she needs. These all can be represented in pictorial form. She can be trained on the use of this kind of communication device. Next, please. We talk about setting factors. Sometimes setting factors may involve conditions that the individual has that may make it more likely that target maladaptive behaviors such as lip biting may occur. So among the things to consider for Debra is that she has been medication non-compliant. If you notice the list of medications that Dr. Keller had put up on the slide, you'll see that she's on a rather complex medication regimen for a number of conditions, and she has a history of non-compliance, which means that she is undertreated and under-medicated for her medical conditions, and that can pose, in addition to pain, she may have discomfort from other sources. Another thing may be the sleep disturbance, because sleep issues have been also noted among individuals with Dravet syndrome. So among the ways we might consider addressing it is to introduce a bed hygiene routine or bed hygiene strategies in which she does things in a certain sequence before going to bed, and that will help her possibly establish a set bedtime more easily. And then we want to explore the reasons for the medication non-compliance. Is there anything we can do to make it more likely that she will take her medications on a regular basis? Would the timing of administration make a difference, or could there be some, or the manner of administration, or is there something about the caregiver approach that could be monitored in order to increase medication compliance? The other piece, of course, is that we want to make sure that the mom is not overly frustrated in her attempts to try to engage Debra in being compliant with either bedtime or in taking her medications. Next, please. So we want to look at all the other considerations we may have. Again, she has a very complex seizure and neurodevelopmental disorder in which autonomic nervous systems can pose a problem. She's prone to seizures with changes in body temperature if she becomes overheated overexerted or overexcited. And these also relate to her sensory integration problem. She's sensitive to light, and again, we talked about flashing lights, visual patterns, and sensitivity to noise level. So we want to help her, give her whatever tools that are possible so mom can help monitor Debra's body temperature and monitor her exposure to outdoor activity and limit access to environmental triggers to seizure disorder and to her seizures, and to provide access to a multisensory environment, whether that's through Snoozlin products or to other resources. Next, please.
So
I'm going to turn this over to Dr. Spivack.
Thank you. So when we take a look at where Debra is right now, what we recognize is that this is a very, very different situation than it was when Debra initially had presented to us 5 years earlier, when she had fallen as a result of her seizures. At this stage of the game, we have a very complex situation in terms of what's causing her to have this recurring biting situation. Clearly, there are medical issues, there are dental issues, there are behavioral issues, all of which really are contributing to her problem. And if we're going to deal with Debra's problems in any meaningful and long-lasting way, we're going to have to address all aspects of it. So when Debra presented to me at this 5-year period with this particular problem again, one of the real important aspects of her care was to make sure that she was on board with neurology, which is that she was on board with a behaviorist. This was critical to making sure that anything that we would do from a dental perspective would carry over far beyond the point where we could obtain some healing for her. As I pointed out a little bit earlier, Debra wasn't tolerating a mouthguard at this point in time, and we were counting on the behavioral aspects of it to go ahead and help her allow a mouthguard to stay in place and to achieve its own work. However, we also figured that we would need something a bit more mechanical to help that mouthguard stay in place and resist the attempts displacement. So working with other members of the dental team, actually working with our orthodontic colleagues. I'm a general dentist, and I consulted with our orthodontic colleagues, consulted with a lab technician that we used to work extremely closely with as well, and he came up with a phenomenal plan to create these little buttons that would essentially be attached to the teeth. We would then make a mouthguard that would be flexible and fit over these buttons, essentially locking the mouthguard into place and making sure that that Debra would be able to keep this in place. We knew that, especially given the amount of oral damage, Debra wouldn't be able to tolerate any of this treatment while it was done awake, so we planned to bring her into the OR. All the lab preparations were done in advance. Several mouthguards were actually made so we could see what she would be able to adapt to, and to give her the ability to deal with different mouthguards over the course of time and see how she would be able to deal with them moving ahead. Next slide, please. Back another one. Right, that's perfect. So we brought Debra into the operating room. We were able to use essentially a clear plastic carrier to carry composite to the teeth to create these buttons that you see in the picture on the lower left side. These buttons were attached to the teeth. They were smoothed out so that they would not cause any trauma of their own. The guards were then tried in, and one was selected, which would be the guard that she would start to wear and she would start to work with. These guards were fairly thick, but they were soft enough to allow her to be able to express herself, to be able to be more comfortable with them. The guards did contain a lip bumper component as well, so again, similar to the last time, she'd be able to allow the lip to go ahead and heal. While she was in the OR, we also tended to her other dental needs. We went ahead and we took care of the periodontal considerations. We did a thorough cleaning for her. We cleaned the mouth that really had a significant amount of gingival inflammation as a result of the long period of going without proper cleaning. We took care of several teeth that were carious at the time as well, and by doing that we addressed the dental issues that she might possibly have that could be contributing to her pain. Next slide, please. So if we take a look at these two pictures, we see the picture before where Debra had been starting to bite her lip, and then we see really only 2 weeks after this, again, a significant amount of healing. By using all of the behavioral approaches, by looking at things from a medical perspective, we were able to get her really back on track. She was able to tolerate the use of Mouthguard at this point in time far better than she was able to before. By having something that she could keep in place, we were able to work with the mom to give her something that she'd be able to get in and out of the mouth relatively easily. Debra was able to express which Mouthguard was really more comfortable for her as well, and this was important too. By giving Debra a little bit of control over what was going on with things, we were able to really get her as part of the treatment team essentially, and I think that contributed significantly towards making things better. Our goal in trying to move this case forward was really on the dental side to allow the lip to heal up. Once the lip healed up, we were hopeful that she would decrease the biting of the lip and the biting of the cheeks as well, and indeed that seemed to be helpful. But we also needed to go ahead and make sure that things continued, that she would not fall back into the lip biting, and this is where the medical aspects and the behavioral aspects really were significant. If we're looking at this case in totality, we've got to look at the fact that moving forward, the dental aspect of it was critical in allowing things to kind of congeal, to allow things to heal up, to make sure that everything was at a baseline where Debra was not in pain anymore and could benefit from medical and behavioral approaches. And it was those behavioral medical approaches that were going to move this case forward and that were going to allow her to be successful moving all the way towards the future. Next slide, please. So, Seth, I'm going to ask if you can start to have a discussion a little bit of some of the contributing factors that we had in this case.
Absolutely. Thank you, Evan. Yeah, and it's been great just sitting back and listening to my colleagues. It really rounds it out, and hopefully everyone's getting some perspective on the importance of how, the importance of the oral health and the psychological issues play a role. But from a medical standpoint, as I'm a neurologist, so even from the medical standpoint, the issues of all the medications that Debra has used, both for seizures and for her behavioral health, and how that can contribute to her psychological or cognitive effects and how she may feel is not a small issue. Whether or not polypharmacy contributes to gait dysfunction or the risk of falling and any further injury that might bring out any further trigger that could start this whole cascade of injury and then triggers again, absolutely. So definitely medications play a role in some way. Seizure control as a neurologist, that's kind of my forte specifically, and trying to do the best we can for individuals like Debra who have challenging seizure issues, whether or not it's from Dravet or if it's a Lennox Gastaut, multiple seizure types, including drop attacks. I'm sure those on the phone who certainly listen and know about this population, those that might have helmets and have protection against injuries, injuries do occur and they're not small. And certainly the quality of life is certainly hampered by not only medication that we use, but also the medication and reduction of seizures is huge. What's important with her or individuals is often they continue to have seizure issues, and what we often do is we go from one drug to another drug, and what's very commonplace, and I just mentioned in Debra's case, she's on just a combination, I say just a combination of Depakote or valproate and Onfi, which is is in a form of a benzodiazepine type medication, not too dissimilar from clonazepam in some contexts. And so often, as many know about seizure control, in a very complicated situation, people could be on 1, 2, 3, 4, 5 drugs, whether or not, and they could be very toxic, and they have a lot of interactions and a lot of situations there's a lot of add-on therapy. So trying to reduce seizure medication to those that are actually workable, or to try to find non-pharmacologic approaches such as vagus nerve stimulator or even surgical options is certainly not an outrageous kind of thing to think about. Corpus callosotomy and others. Medicinal marijuana has been coming up a lot in press and in some research to show that even in Dravet Syndrome, components of medicinal cannabinoids and marijuana are now showing great promise. And so I myself in my practice have been in certain individuals who are very refractory and really having difficult times with their seizure control and medication not working are certainly open to trying non-pharmacologic approaches as well. The issue about spasticity control, Debra has gait dysfunction, she's on baclofen, and because of the increased tone that has happened to her, she has a very high risk of falling because of her tone. So trying to address the tone and reduce tone is certainly important, but then sometimes it's a double-edged sword because of the medication we use. And gait dysfunction certainly turns into issues of safety, falls, and injuries, such as happened as happened before in Debra's case, maybe not elicited in this more previous case, but it certainly does happen. And I'll let Dr. Esralew talk about psychosocial and neurobehavioral, as she's already alluded to in her previous chat.
Right, so thank you. Debra is a very complex individual, and one of the things to think about that complexity is whether she has anxiety, as we touched upon earlier. And so one of my goals would be really to try to address that, get her as comfortable as possible. And we found out that social attention was one of the factors maintaining her maladaptive behavior. So we certainly want to pay attention to this going into the future. As Evan was indicating, we see this as an evolving picture. Thank goodness her lip is healing, but we want to make sure there's not a reoccurrence of this maladaptive behavior. So we are finding positive ways for her to get social attention. The other aspect of the psychosocial situation for her, a factor, is how we best support mom, who is her primary caregiver and health advocate, and make sure mom has the support she needs and the training that she needs in order to be effective with Debra and maintain behavioral health as well as medical wellness. Going forward, if we're successful in getting the reduction or elimination of lip biting, we want to go on to other territories such as medication compliance and get her more regularly taking the medication she needs for all her complex medical conditions. And we want to address environmental stressors, make sure that we are reducing those factors that have been stressful for her so that she could be more comfortable and begin to follow a positive routine that involves whatever skills building she might need, including functional communication and preferred activity. So those are my considerations from a psychosocial and
Lucy,
a neuro.
I was just handed some new information about Debra. I learned something right now. We keep talking about the single mom. Well, I just learned that actually this is there's a recent divorce, and there's actually issues going on that actually have happened to to her father. So did you say that there is, so what is it in terms of her father? Well, there's been a lot of infighting between control and who's going to have support for Debra. So this came across in a subsequent interview that with the mom and having a lot of concerns and help, there's another factor with other family members, including, this divorce that happened in the recent past, and how that. What do you think? Maybe that's something going on behind the scenes. So
that may certainly be a factor that adds overall to her stress level, and that's an important piece of information to consider. Not only in backing up to kind of psychosocial aspects of individuals, families that support individuals such as Debra who have severe disabilities. We know there's a very high rate of divorce. And there's a lot of marital stress and conflict that sometimes is a result of trying to care for an individual such as Debra, who's now 35 years old, and so that's a long period of time in which to care for somebody with significant and complex disabilities. So we'd also want to make sure that there's some support to both mom and dad, and for them to understand that their communication with each other could very well impact upon Debra and her stress level.
Absolutely. Yeah. Thank you. And so oral health too, Evan, the issue about just oral health maintenance in terms of the baseline of keeping oral health for her. What's your sense about how that can play a role over the overall issues in terms of maintaining function for oral health and preventing any further challenges for her?
Well, clearly the dental issues and the oral issues that she has are going to be ongoing, and one thing that really does become a concern, mentioning the fact that now there are family stresses, that's definitely going to impact Debra, especially given a limited ability to communicate. A lot of those stresses are taken out by grinding, by bruxism, and that's going to manifest itself very often as TMJ pain, as pain in the teeth from bruxism. So it actually creates those dental and oral issues as well and makes things even worse, which is why when we're looking at what's going on within the dental realm, we also have to kind of expand our view a little bit and make sure that we're looking at what the psychosocial, what the social and the family situations are for our patients too. Specifically looking at the oral health, we also need to make sure again that mom and dad do have the supports. Whoever is going to be taking care of Debra's teeth has to know how do we brush the teeth, what do we do in terms of proper oral care, in terms of mouth rinsing, in terms of maintaining a clean oral environment, in terms of checking the mouth on a regular basis to make sure that given the bruxism she's not fracturing teeth, making sure that we're aware when she does start to perhaps bite again. If she does, we want to catch things early before they become critical issues. So essentially monitoring at a very, very early stage, making sure that the parents know what's going on, what to look for, and make sure they understand how important it is to pay attention to the oral environment. There's a lot going on with Debra. As was noted before, very, very appropriately, she's a complex patient. There's a lot going on a lot of different levels for her, and mom and dad have apparently their own stresses as well, and sometimes some things tend to get overlooked, and sometimes it can be the dental environment, the oral environment that gets overlooked. So making sure that mom and dad understand, listen, this is important, is something that we need to really stress as part of our role as dental care providers. Knowing how to brush the teeth, knowing how to care for the teeth is important, knowing that they need to come back on a very recurring basis. For most of our patients in routine private practice, we recommend the patients come back, say, once every 6 months to go ahead and get the teeth cleaned. If we have someone like Debra, where we're seeing far more complex situations, where we are concerned about little issues becoming bigger issues with very, very little stimulation, then we're going to want to see her far more frequently. We may want to see her every 3 to 4 months. We may want to see her every 2 months. And depending on how we're seeing the oral care come along, we may want the parents to come back really repeatedly over a short period of time so we can see that really they're getting into the pattern of it. The other thing that I'll say is that as Debra gets more and more into a repetitive concept of care, where we're seeing over and over again, every day we have the same routine for toothbrushing, the same days, the same times, the same way that we're going to care for the teeth, she's going to come to accept it far more. And the fact that now the lip is healed up, it means that she's not going to be in as painful a situation, so she should be able to accept that. This is going to tie into how well she's going to be able to eat, what she's going to be able to eat. We're going to want to bring nutritionists into this as well, which is one factor that we need to again consider when we're looking at expanding beyond our own individual silos. To talk about what can we possibly do from a nutritional perspective that's going to be good for her medically, it's going to be good for her in terms of the type of feeding, and it's going to be good for her from an oral perspective. So all of these areas really tie together extremely well.
Well, we definitely know as we're talking tonight, why is multidisciplinary approach important? Well, I think hopefully we gave the sense, and Evan, you mentioned the issues about silos, and I certainly think that many individuals on the phone, who, without asking everyone, that I'm sure they can appreciate, the issue about concern for silos. Certainly each practitioner into themselves practice in their own way, they do what they do, but certainly in someone as complicated who has a developmental disability, the concurrent oral health, the mental health, the medical health, and the multiple medical issues, it's important to kind of really pull it together, and really the best case scenario is when you do bring everyone together it does lead to better quality of their care. That is certainly the utopian way that you would think about it. Why it's important is to really bring best practices and hope to best outcomes for the individual. Right now, we're actually at the end of our talk, and I'm going to kind of bring in both my colleagues into this conversation. Do you guys have anything to add in terms of a concern or question about the obvious, I can say obvious, the need about why it's important as colleagues for us to kind of work together, like why it's important?
Well, I just want to add something with regard to the multidisciplinary approach. We don't want to leave the family out. So, you know, we're concentrating as healthcare providers in a broad sense, but we need to be aligned with the goals of the family and include the parents. Now that we've established there are two that we're going to be concerned about, so that everybody is on the same page and communicating with one another, so there's not any therapeutic erosion and loss of information in communicating between one or another caregiving professional, one another practitioner, and the family. I'm particularly concerned about how mom and or dad are going to be trained to provide the oral care, and also to be alert to the seizure disorder and the neurodevelopmental issue that Debra has. You know, so I wonder what your thoughts are about that. How do we pull the family in most effectively?
Well, I think one thing that's important is who really is involved. It mentioned here who's actually the main provider of ongoing regular care, and that's not a small issue. And whether or not the parents are split 50-50 or such has to be important, but that has to be elucidated. And certainly if the provider of care, the practitioner, doesn't really actually know, they might be given the information or suggestions to one support individual, family member, and it may not be fully effective until you are bringing the other ones involved. So you really have to ask the questions. You really do have to ask the questions. Otherwise, any suggestion you have as a practitioner is not going to be come to a great solution or solving it because of that. So you do need to know.
And I think the other thing that's important, and you know, Lucy, you raised the question of, well, how do we actually provide this training to the parents or to the caregiver, whoever's involved with the care? One of the things that we really have to focus on, in addition to just looking at Debra's mouth, is, you know, what do the parents think about oral care for themselves? How are they looking at this from their own perspective? If mom and dad aren't taking care of their mouths, if they have a history of oral neglect, then are they really going to look at Debra's mouth really important? Are they going to really appreciate the importance of oral care? And the other point that you made, which is an extraordinarily important point, is how significant the demands are on the caregivers for the parents of Debra, for the parents of patients like this. They very often neglect themselves. And so these are parents who they may bring their kids to the dentist every 6 months, but they may not have seen the dentist themselves for 6 years. And so the importance of them taking care of themselves, understanding, hey, this is what you need to do. Have you been taking care of yourself? What do you do for yourself? What's going on in the home? That's a very critical component of the education. And the one thing that we also have that's very important that kind of does help us is we will bring our patients back in on a very recurring basis, and we'll constantly be able to reinforce what the good points are, what's going on well, what they've tried, what they haven't tried, bring in all the different technologies that there are, whether they're high-tech or low-tech, and make things really, really work for Debra.
Yeah, one of the benefits of working with a behaviorist can be that the behaviorist goes into the home and helps establish routines. So we can establish an oral health routine, bedtime routine, medication compliance routine. You know, how do we get all these tasks that are important for Debra's well-being taken care of during the course of the day? And you know, how can mom or dad, you know, help deliver this without being so totally overwhelmed, as you're saying, that they're not taking care of themselves? And this whole routine breaks down because there's no real support for that.
Yeah, they're so important, Lucy, to recognize the social need that you're mentioning. To actually, so if I have an individual, family member, or patient come to my office, and I have some concerns about all these things that they say within the four walls of my office setting, then I make these somewhat complicated suggestions. They go home to an environment that might be in chaos. Then I think it's hugely important that wherever they go to does get that level of support. So it's hugely important for any practitioner to really appreciate what's going on at home and how you might suggest to them where they can go. So I really definitely think the practitioner themselves definitely has some importance to them on at least bringing it up, mentioning it, or certainly when you're working in developmental disabilities, hopefully already have a network that you can reference or refer to be able to reach out and say, I want you to kind of call or reach out or consult with my colleagues in behavioral health, or as you're mentioning, to go home and help them in a social way.
Mm-hmm.
It's a shared responsibility.
Yeah, I think that's very important. I think we, all of us that are involved in the care of persons with intellectual and developmental disabilities essentially maintain a Rolodex of sorts where, we know the names of people and the contacts of people that we're going to be able to reach out to in the various fields, and that really is critical. One thing that we have to remember is that every one of our patients is really very individual, and there is no cookbook method of approaching any of our patients in any ways. Even just looking at something as simple as toothbrushing, perhaps. If you're dealing with a patient in a wheelchair, well, providing the oral care in the bathroom in front of a mirror is not going to happen. The use of water play and water therapy is extraordinarily important. Lucy, you brought that up a couple of times, and and that's a fantastic area in which now you can have the patient go ahead and brush the teeth or have the teeth brushed while they're interacting with water, while they're doing something that has a good feeling for them, that's going to really stimulate them in a positive way, that's going to have good, good vibes for them. So all of these things are really critical, and this is why it's important to really be able to have other people on this team that we can all reach out to, that we can say, listen, how are we going to best address things for this particular patient?
Yeah, in the last 15 minutes, I know we want to leave, I guess, some few for Q&A, but I think how do we actually deal with the reality of that we want to work together? How do we actually accomplish this? And I think the one thing is not settling for second best. And I think the one thing that maybe a lot of families or others might think that they haven't been able to feel that their practitioners are really communicating with each other, they're not talking, not working in a team approach, and maybe people just settle, and this is they might think that this is the way it's got to be, this is the so-called quote-unquote norm of care for my loved one, and I think that's nonsense. I think people who care for their loved one should have a high expectation of please communicate, please reach out to the other practitioner, please let them know, at least in a way that they are in the loop in some response and they're in the knowledge and they feel a tacit responsibility that they are working together. So I think the families, the support organizations have a huge responsibility into themselves of trying to work or try to push towards having their practitioners work in a disciplinary from their standpoint. What do you guys feel about that, as well as other aspects of trying to accomplish a multidisciplinary approach for care? Evan, what's your perspective?
Well, I'll tell you, one of the most important things that I see is the need to really engage the concept of a multidisciplinary approach very, very early on in care. Mm-hmm. When we saw Debra the first time, she already came in with a problem. But there are a lot of patients that we're seeing who are coming in without anything very, very heavy duty going on, without any really bad issues. When I see a patient on intake, it's very important that I know who is your neurologist, who is your behaviorist, do you have a nutritionist, do you have a cardiologist, an epileptologist, whatever it happens to be that's going to be involved with the care for this patient. If we can establish that early on and we know who the members of the team are, this allows us to really reach out to them from a very, very early level and a very early point and be able to establish that rapport to discuss care in a much broader sense. The other thing that allows us to do, too, is kind of find those gaps where maybe there isn't a person that's caring for this patient. We see a lot of patients who will come in where the seizure disorder issues are being handled by the primary care physician. The patient hasn't seen a neurologist in a very, very long time, if ever. And so just the recommendation, hey, you know, you need a neurologist. You should see somebody. That's really critical. And I think that's a very important aspect from the very, very beginning that we can do, that if we all do this and we all look at that component, we can really start the conversation and we can really engage the family and engage others within the care team.
Lucy, and maybe we can wrap this up. Yeah. Lucy, what's your final perspective in using aspects of accomplishing multidisciplinary care and approaches?
Yeah, I agree with Evan that it starts at the beginning. I mean, I think we have to role model that this is the way we work. These are complex individuals, and we need an interprofessional team to review all aspects of this person's care, and then advocate with, because many of our the clients that we have, and I'll speak from my perspective, are in managed care, and it's important to, if we're on the panel for managed care, or you know we are involved in some way in contacting managed care, that we advocate for this complexity to be supported by different specialists. And I think that's what we put out there, you know, again with the questions that Evan suggested at intake. A lot of people don't even understand that concept. A lot of practitioners do not. They're used to operating solo and not used to really connecting up with others who are involved. And I cannot even imagine working that way. So I think it starts with and ends with our advocating for a multidisciplinary approach.
What about technology, Lucy? Is there any thoughts on usage of
you know that I'm going to be mentioning Echo.
What's Echo? What's that? What is that? I've heard of it. What is it?
Extension work. You've heard of that community, and I'm sorry for those who are wondering what we're laughing about. Is both Dr. Keller and I are involved in extension for community healthcare outcomes, which is ECHO. It originated with the University of New Mexico, but it's a video conferencing based review, interprofessional review of complex cases where individuals like ourselves, the colleagues on this webinar, review cases and help local providers co-manage these complex cases. And I think that is the wave of the future. I really do. Using Zoom platform.
Right.
Yeah.
Yeah, and certainly currently electronic medical records within systems are trying to do it, but sometimes they're inclusive or exclusive. They don't often go to different providers within the service. So there's a cloud system that in the future that other ones can share data and information. So I think technology hopefully will be part of a solution in the problem of joining us together. We have about 9 minutes left, and I think basically for the interest of time, Michael, I think maybe we should just kind of finish here. And Michael, were there questions that folks submitted?
So far there's only been one, but if the participants would like to take this chance right now and ask any questions that they have about the case or about anything regarding it, more so about any clarifications on the medical, pharmacological, or behavioral side. The one question we have,
it was related to oral medication, wasn't it? I kind of peeked at it. A question
right.
of, is the medications were taken via PEG or orally, and I think maybe that was related to, I don't know if it was seizure medication, and I kind of briefly looked at it. Is that relatively what the question was about?
That's correct. Essentially, how is Debra being given her medication if she's having difficulties orally?
Well, definitely. I mean, this is an amalgam, so it's kind of a pseudo-fictional case, and I think compliance was an issue. And I think one thing that happens often in people who are, somewhat oral, and we can give them a chance of trying to take food by mouth. You want them. You do really want them to encourage them to try to swallow themselves. It gives them that stimulation and that personification that they actually can do it. But again, at the time, if they're not able or non-compliant, having having the PEG, I think, is a great aspect. So I know that for myself as a neurologist, when I talk about Depakote specifically, I know that in that particular medication, it has sprinkles where you can actually sprinkle it in food, or certainly you can put it into the meals in different ways. So there's always tricks at which people do use these medications, whether that's through oral means or through the PEG as a backup. So I think having a PEG is actually a good backup. Unfortunately, unfortunately or not, having a PEG is not always the option, where people are only through mouth and they don't have a PEG backup, and you're in trouble because basically you don't have another source of getting medications in. So I'm not sure that answers the question in this situation. So folks, I don't know, Evan or Lucy, if you have any questions or thoughts about the issue about whether or not the person from a behavioral or oral health standpoint is taking their pills orally or not, how that might be important from your perspective. Evan, what's your sense about it?
Well, one thing I will say is that's very, very important from the dental perspective when we're seeing a patient like Debra, to ask if the patient is taking the medications. That's really critical. First of all, are they taking even the analgesic medications, because we want to achieve whatever degree of pain control that we can to allow everything else to move forward. The fact that Debra has a PEG really does help in this situation. There are lots of situations where we've seen where there's pouching of medications, where there's just outright rejection of medications. So using the different forms of medications, whether it's a sprinkle type, whether it's a liquid medication, really is very important. But we definitely have to ask the questions. We have to bring that up with the parents or the caregivers.
Absolutely. Lucy, any comments on that from your standpoint?
Well, I mean, my interest would be just that she takes medication compliantly, so that I'd be looking at whatever administration is most likely to be associated with her taking medication on a regular basis.
Right. Now, Lucy, you made one comment which I was kind of interested in about what is the behavior that the family or parent does to so-called entice an individual. I can imagine being a fly on the wall if I'm a father with children that are a little older, but think about how I would say, or what would I say to my kid to try to encourage them to take your medication. So sometimes what you say is not the right thing to say. Maybe there's things that you're doing or your own personal behavior that can contribute in a negative way to their outcome, right?
Yeah, well, the approach during the time that, we could imagine, who knows, that might be that, we'd look at when Debra was most compliant and when she's not compliant, and what does that mean? Was she combative? Was she, did she just outright refuse? What was the nature of the non-compliance if the mom or dad were administering the medication? Did this come up during times when she witnessed her parents arguing? Did this have to do with the tone of voice or the way in which mom prompted her to take medications or gave it to her? I mean, if she gave it through the PEG, so that's another issue about how she would have been non-compliant. Yeah. True.
Now, Lucy, we have two more quick questions. Evan, and Michael, I do see them, and there's a question, I'm going to steal it right from you, I do see it, the question on snoozolin in multi-sensory environment. And Lucy, I know that you have some good knowledge about that. I know that you may have seen that in Orange Grove and other places. Can you give a little story about snoozolin in multi-sensory environment?
Yeah, well, that's a way of exposing individuals who tend to be lower functioning and with sensory processing problems with an enriched environment. And the American distributor of snoozolin products is Flag House, and they do have a full line. It was originally in one of the Scandinavian countries, actually was developed for individuals on the spectrum, very low functioning, and as you know, have sensory processing problems. And as we spoke about it earlier, Debra with her Dravet Syndrome might well have autistic-like traits, which include also sensory integration problems. Now it's also being applied to individuals with dementia. Absolutely. And it's, fiber optics, aromatherapy, various kinds of tactiles, so all the senses are engaged in this environment, and it's thought to be very relaxing. It can also be used to help stimulate individuals who the thought is that they need more stimulation because they're too lethargic and they're not
And I believe,
active
Lucy, it's
enough.
not true. Isn't there societies or organizations that basically talk and deal with this? I believe that even our colleague Rick Rader is involved in that. I don't know if that you know that or not, but I think people could look this up on the internet and learn a lot more about it.
Right, absolutely. And I don't remember, he had some kind of society involved with multisensory environments.
Yes.
And again, it's thought to be a way to engage lower functioning individuals who might not be able to be involved in activities or to really process sensory information independently.
Right.
And you know, it's a good opportunity to look into that for some.
We have one more question. Michael, do you have that last question?
Yes, the last question. It's asking if you think that jaw and dental pain as an inducer of lip biting, if you think that the patients find it as like a sensory disintegration, or if the patients become fascinated with the texture of the damaged skin.
Absolutely, absolutely, and I think this is something that we see even in people without cognitive impairments, where you do sometimes start. You have that lip bit. You have sometimes perhaps after, let's say, local anesthesia for a dental procedure, you tend to kind of bite, and you're kind of biting and you're biting a little bit more. The issue is where it becomes something that is not stopped, where it becomes something that's actually injurious, where you're causing soft tissue damage, and that's where it kind of crosses that line, and that's where you go from a situation where it can stop by itself and then to the point where it cannot. Where it can't, now you need to look really at the behavioral issues, and you really need to see what's causing this, what's interfering, what's actually contributing to it as well, and what can we do to make things better. On the dental perspective, you have to eliminate certain interferences. So you would eliminate dental caries. You would try to make the periodontal condition better. All the things that we spoke about before. But that's only the dental side of it. For many of our patients, it goes far beyond that, and the dental component of it really is only that one aspect of it that we can bring to the table. It then comes to a lot of the other issues as well.
Great. All right, I don't think we have any other questions at this time. So, I don't know if any of you have any closing comments or anything.
I'm actually just going to thank you all so very much. I think it's been great, and I certainly I think for me personally, seeing it in action and talking to my colleagues on the phone is personally for me it's exciting to know that we all can work together. And I think I encourage everyone listening, and even I go back to myself, is trying to expect that and want more and more to do that, and expect that from our colleagues, that we want to work together, and it's obviously the dividends that pay off are tremendous. They really are, and expect that from your care. Any final? How about yourself, Evan? What's any final comments?
Well, I definitely want to echo, Seth, what you said. This has really been very, very enjoyable. It really has. The whole process of putting this together and working with you and with Lucy has been fantastic. I really enjoyed doing this. And it really, and the one thing that I want to kind of really point out to this, and especially to people who do tend to kind of work essentially within these silos, as many people in private practice tend to do sometimes, we really want to we're looking at a fairly complex case that definitely just cries out for the need for a multidisciplinary approach to care. But for pretty much all of our patients, we really need to look at the larger pictures that are far beyond ourselves and our own area of specialization, and really look to seek out who else is involved in patient care, because if we can do that, the quality of care that we give to our patients is going to be far, far greater, and the true professional satisfaction that we achieve is really going to be greater as well. One of the real aspects of special care that I find that's really enjoyable and that really drew me in initially was the whole issue of being able to work with people outside of just the dental profession, and that's made a tremendous difference for me and definitely for my patients as well.
Thank you very much. Lucy, what's your perspective or final words?
My perspective is ditto and ditto, and thank you for the opportunity to work with the two of you on this. This was very interesting.
Pleasure.
Now, and Michael, we have our moderator and student, a young pup coming up in the field. Where do you view yourself and what you're learning or seeing from your perspective as a relative newbie?
You know, I'm just trying to absorb as much as I can and hope that some of it sticks. And as an older brother of someone with severe intellectual disabilities, I appreciate the collaborative effort, and I urge all other clinicians out there to reach out and to be as succinct and work together as much as you can as possible, because the people who you're treating are our loved ones. So great work, and I'd like to thank all of you once again for joining us, and thank our three presenters for an excellent presentation. So I hope everyone has a great night.
Thank you all. Good night, everybody.
Good night.
Good night, Michael. Thank you for facilitating.
Yes, thank you, Michael. Great job.
Thanks. Good night.
Yes.